Welcome 400 to week 8, where we'll be discussing health promotion in rural and remote areas. I'm Stephanie Dorn, and I'll be facilitating this week. I'm here with my dad, Stephen Dorn, who is a northern nurse that operated in numerous areas across Canada in these rural and remote, primarily Aboriginal communities. So I thought it would be helpful to interview him on his experience and how he provided health promotion and services in these communities. Thank you for being with us.
You're welcome.
As a northern nurse, can you explain how you provided health promotion and health services in these communities?
Yes. In the afternoons we had clinics. We had clinics set aside for chronic disease, well woman, prenatal clinics, chronic disease clinics, immunization clinics, and sometimes they were very well attended. Other times you sat half the time twiddling your thumb, wishing you were out in the community doing some other work.
Did you see any mental health and addiction services offered?
Yes, there were some addiction services offered, but they social workers with some extra training, and they were not within the community. They may have, let's say, just hypothetically, they may have worked out of Yellowknife, and they may have covered 4 or 5 different communities in the north, and they'd come up as need be or once a month for a night. But that was it.
Okay. So was it difficult to get people to attend and comply with some of the information and education that you provided them?
No, that was our biggest handicap was compliance, and a lot of it that had to do with history of trust and this passed down through the generations. It got better now with the newest generations, and leaving a lot of that stuff behind, especially with the new prenatals. They take a more active interest in the in their children, in their babies, and they want to know more.
So what generally brought people into the clinic?
Urgency. First thing in the morning, or after somebody had to be on call every day, and the weekends, we generally got the community understood what the days were and what they were for, and what the afternoons and the mornings were for. But that didn't keep them from coming in for a cut finger or a child with a fever, even though you may have seen them during the week and told them it's going to take a week for a chest congestion.
So did you see the use of traditional medicines and practices before
yes.
they came to you?
Absolutely. And I saw most of them with the First Nations people rather than the Inuit that I worked with. Some of the things I saw were really, really quite amazing. I had CHR, which is Community Health Representative, came to see me in the morning and told me that this young boy had had a very serious axe wound to his hand the night before, and it's going to require some stitches. So I brought him to the clinic, and it looked like somebody took a bunch of snuff and sprinkled it onto the wound, and then closed the wound on top. Well, opening that wound up, I didn't know what that stuff was. I thought it was dirt. It was like peeling skin apart that had been held together with crazy glue. But I managed to get it open, and I flushed it out and cleaned it out and then sutured it up. Well, it wasn't long after that, another child coming in with the same thing. And actually it was a young woman. And she had the same thing, the same stuff on there. And I asked her, I said, where did you get this stuff? What is it? And she told me, I got this from the medicine man. But I looked at that wound and I said, I'll be damned if I'm not opening this thing up again and go through what I did before. And she came back in 3 days, and that thing looked like it had to be closed with crazy glue. It was just absolutely no infection involved in it or anything else. And for all the years, 10 or 15 years that I worked with the First Nations people, and I wanted to get to know who these medicine people were, and I couldn't. They wouldn't divulge anything to me, no matter how much I tried, no matter how much trust I showed them, how I promised the house and that I wouldn't divulge it to anybody else. And that goes back to the time just 10 years before, where the Aboriginal people were we'd be jailed for practicing Aboriginal medicine on the reserves. So you could understand why this prevailed, this attitude.
So when you saw traditional medicines, if it was working as a nurse, you just didn't intervene and try to superimpose Western medicine?
No, I certainly did not. If I always had them come back in about 24 hours or 48 hours, depending upon the condition, the severity of the wound. The community health representative, I've always asked her to peek in and just to see how things are going. If it looked like there was infection setting in, to please invite the person to come back to the clinic. And I have to say this with all honesty, I never had one incident out of dozens that became infected.
So you saw the value in the health practices of traditional Indigenous medicine, but they weren't supported by the government and the health system that you came from.
Well, not by traditional medicine as we know it, but they were certainly treasured and secretive about it and used. I mean,
So in terms of elderly in these communities, how were they cared for?
people, but we had elder care people that would go around on a daily basis, and they had a list of people that they had to visit and clean their house up, do their laundry, check the fridge, make sure they had enough food, seeing if their activities of daily living were up to par. If they weren't, we had to discuss that and get somebody to go in on a daily basis if need be.
So you worked closely with these aides?
Oh yes, absolutely. We had a meeting just about every day when they got back.
Okay. So was there an interprofessional team operating in most of these communities, or was this kind of from the lucky few?
Well, at the beginning it was like that. Later on, they're like the nurses, they're posted up there, they stay up there.
So you've seen the consistent development of these interprofessional teams over the expanse of your career?
Oh yes,
What did you do in emergency situations?
dealt with it.
Can you expand on that?
Well, for instance, we had, these are the days of the skidoos, and a lot of people were having, fractures were a big thing. We were taught to take x-rays and how to reduce fractures and to cast them and to, if they're really, really, really severe, open a splint cast and medevac them out to have a Harrington rod put in it or whatever. If it was just an arm, we just deal with it up there ourselves and send the x-ray down at the end of the month to the doctor to have a look at.
So you had to operate within an expanded scope of practice to care for the needs of the communities.
Absolutely. The more you did it, the more comfortably you became with it. The more backup you had, and the more familiar you were with the community, the more relaxed you were, and the more efficient you were, and more professional you were, and more of help.
So a lot of the things that you mentioned there in reducing fractures and doing and suturing people up, these are not things that as an RN that I would be that would be within my scope of practice. So, and if I were to do, I could there would be major repercussions. So what kind of protection did you guys have for operating in this expanded scope of practice?
Well, when I went up there in 1980, that the government had a law, the federal government had a law that the nurses were operating in these communities unless they did something absolutely ridiculous, like an open reduction of a fracture. They could not be sued.
So did you feel like you had adequate resources for the activities that you were sort of expected or just ended up having to do? You said that you worked 7 days a week as opposed to 5 days a week. So where were you lacking in resources and support?
Well, we're always lacking in manpower, staff. There was always a problem, and qualified staff.
What would you have liked to have seen different now? Like if you were to go back to the northern communities, what kind of supports would you hope to see?
Nurses that are going out. Trust is really the big thing. and lack of trust leads to poor compliance, and poor compliance leads to poor health.
So where did you see the greatest improvements in these communities?
I suppose the largest one would be ranked in that we're pretty well staffed with 6 or 7 people, and there would be a doctor there for about a week a month. She was stationed there, so we always had her to call on if.
So just to quickly recap, in terms of health promotion, you guys ran a number of initiatives, but what I'm hearing that the biggest issues from getting people to attend and comply with the education and their treatment was a lack of trust, and that in order to develop that trust and be able to promote health in the communities, that you spent a lot of time developing relationships and trying to accept and incorporate traditional medicines and values as being valuable.
Yes, but you can't forget that the most important element is education. Made sense.
So once you educated them and then they started to see the benefits of those practices that you taught them, did compliance increase and get better?
Absolutely.
Wow, lots of health promotion definitely happening, and it doesn't sound like it happened in a silo, where here in urban centers we might be a community health nurse where we're working in health promotion, or we're in acute care in the hospitals where we're dealing very much in secondary or tertiary care, but in these rural settings you were kind of the be all and end all of it.
Exactly. From delivering babies to setting bones to
Well, thank you so much. I think that about wraps up this discussion for today. I hope everybody finds that helpful, and I look forward to facilitating the week. Again, thank you so much, Steve, for joining us.
Good luck, guys.